Shoshana Fishbein.
Hi, this is Shoshana Fishbein. I have no conflicts of interest. Next slide, please. Thank you to VRBPAC for all your hard work during the COVID-19 pandemic and also every year to ensure that our vaccines are safe and effective. It's fitting that I'm speaking today on behalf of families fighting flu as you discuss vaccines for children. Our organization was founded when all children 6 months and older were not recommended to receive annual flu vaccines. The founders of our organization are parents who lost healthy children to what they thought was just the flu. I'm here today to thank you for your hard work in ensuring children have access to safe and effective vaccines, because our organization uses stories to show how vaccines can save lives. Slide 3, please. We want to recognize the important work VRBPAC does every single year to make recommendations about flu vaccine formulations. Although flu vaccines are not perfect, this committee helps to ensure that the supply in America matches the strains most likely to circulate. Our stories are a cautionary tale of what happens when people do not take the flu seriously, and we've seen many parallels with COVID-19 and in children. We thank you for this important work that often goes unnoticed. Lastly, we want to acknowledge the work that went into the last pandemic, H1N1, in formulating pandemic vaccines over a decade ago. Many of our stories are people who were hospitalized, on life support, or died from H1N1 flu, many of whom were children. And we know it's important that COVID-19 vaccines are safe and effective for children 5 to 11 years old because children can and do spread COVID-19 and flu. The work that VRBPAC does is meaningful and necessary. Families fighting flu is just one of many examples of why prioritizing science and evidence-based practices is literally life-saving. Thank you for your time and commitment to science.
Thank you. The next speaker is Dr. Robert N. Edmonds.
Dear Committee, I have no financial conflicts of interest to disclose. Previously, I have reviewed the latest statistics of tinnitus with the Johnson & Johnson trial data as seen on the slide. While my main goal is simply to encourage early and appropriate treatment for this rare event and support continued COVID vaccination, I have also encouraged investigations into this matter because I have hoped that there would eventually be study into the process that results in this condition. Why? Because in early January, I got my first shot from a different vaccine, and yes, a different platform, Moderna. 2 to 3 weeks later, I developed tinnitus on the right side. I then received a second dose in early February. As with what happens to many who develop tinnitus after dose 1, I then worsened. The tone became louder, and I developed near constant headaches, right side facial pressure, numbness, paresthesia. A few days after my second dose, my wife then received her first dose of Moderna. By early March, my wife received a second dose, but then she too developed tinnitus about a week later as well. While my other symptoms later resolved, both my wife and I continue to experience constant tinnitus. At the time of onset, we had no close contacts, and I later had a negative nucleocapsid test. I've also had normal scans and 2 normal hearing tests, something that appears unique but common to many with this adverse event. Because of the staggered vaccination timing for us as a couple, but with symptom onset still coincidental with vaccination, it is hard to shake that this is not somehow a related, difficult to detect, low-frequency adverse event, despite not appearing in the trial data, something even my providers work under the assumption of as described in their notes. It leaves my wife and I in a challenging position. For one, is there some shared environmental exposure that increases the correlated risk to our young daughter for experiencing this event in the future, something I would never have dreamed of worrying about prior to this. I know tinnitus is not considered serious, but this may be a permanent, lifelong condition. Also, it has led some who have developed tinnitus after COVID vaccination to thoughts of suicide due to the severity of the constant sound. I can also say that one individual, Dr. Timothy Boring, completed suicide after battling tinnitus for 7 months after COVID vaccination. His daughter gave me permission to mention his struggle here today. As I have mentioned in other comments, severity needs to be considered when determining a background rate of tinnitus to compare against. In Phoenix, ABC 15 ran a story discussing how there are over 10,000 reports mentioning tinnitus in VARs. The story highlighted me and two others that developed tinnitus. One, a member who once sat on this very committee. A little detail not widely known, all 3 of us are a part of a tinnitus adverse event pair. I know of many other tinnitus pairs not in the story as well. Another unique curiosity that's gone unstudied. I know we are a small number in a sea of misery in this pandemic, but we rolled up our sleeves, defended our communities, and now we are asking for study into this issue. Thank you for your time.
The next speaker is Dr. Andrea Klein-Tilford.
Greetings. Andrea Klein-Tilford. I have no conflicts of interest. I'm a pediatric nurse practitioner and president of the National Association of Pediatric Nurse Practitioners, a professional organization representing more than 8,000 pediatric-focused advanced practice registered nurses. We support the timely and complete immunization of all infants, children, and adults in an attempt to maximize the health and well-being of all people. The last 20 months have brought immense strain to the world, including our nation's more than 20 million children 5 to 11 years of age. Our children have been pivoting in all areas of life. Slide 2. The strain has been immense and has resulted in physical and mental health challenges that will undoubtedly have lasting impacts on social, emotional, and mental health. In a poll conducted by researchers in Chicago, 71% of parents or caregivers believe the pandemic impacted their child's mental health. Pediatric nurse practitioners are on the front line in primary and acute settings, encountering these challenges in our children each and every day. There has been an alarming increase in child and adolescent anxiety, depression, and suicide. According to the CDC, mental health-related emergency department visits by adolescents increased by 31% in 2020, and at one point during the pandemic, emergency department visits for suspected suicide attempts in girls was up 51% from 2019. Additionally, eating disorders, sometimes deadly, increased 62% during the pandemic, and an estimated 140,000 children have lost parents and caregivers due to COVID-19. Let's not forget the physical ramifications of COVID-19. Children can and do suffer acute illness, multi-system inflammatory syndrome, and long-haul physical symptoms. Over the last several months, the number of COVID cases in children has substantially increased. Data from October of 2021 reveals more than 630 pediatric deaths from COVID-19 and at least 46 pediatric deaths associated with MIS-C. Children have paid a significant toll, and we have the ability to alter this trajectory. Right now, we rely on masking, physical distancing, hand hygiene, and surrounding children with adolescents and adults that are vaccinated. Without other options, these strategies were acceptable, but are not a solution and leave a tremendous gap in protection for our children. Slide 3. NAPNAP urges the FDA to authorize the Pfizer-BioNTech COVID-19 vaccine for children 5 to 11 years and supports widespread, equitable rollout to every eligible child in the U.S. using all possible vaccination sites, including primary care offices, schools, health centers, pharmacies, pop-up sites, and mobile units. COVID-19 vaccination is safe and effective, and with the adjusted dosing for children 5 to 11, we can protect our school-age children immediately and further shield them from short and long-term physical and mental health consequences. Let's use the newly provided data on the Pfizer vaccine and to deliver comprehensive, equitable immunization to all children 5 to 11 years of age. Thank you for this time to share the views of the National Association of Pediatric Nurse Practitioners and my own views as a mother of 2 children under 12 years of age.
My name is Josh Getsko. I'm a senior lecturer at the Hebrew University and have no conflicts. Expanding the EUA to children is unnecessary, premature, and will do more harm than good. Slide 2. There is no emergency for children, especially healthy ones whose risk of severe illness or death is almost nil. Kids with pre-existing conditions and prior COVID infections were not included in Pfizer's study, so including them in the EUA is negligence. Slide 3. Correction, the 2268 number is for all subjects. Pfizer's trial is woefully underpowered to detect specific safety concerns, such as myocarditis, just like the adolescent study was. And if they weren't able to detect an unexpected safety concern there, they wouldn't be able to here. In Pfizer's study, only 0.5% of controls were dropped due to important protocol violations versus 3% in the treatment group. The odds of that happening by chance are 1 in 10,000. This deviation is poorly explained with no ITT analysis. The study is not double-blind and may be subject to biases. Most VSD safety monitoring programs have not reported results. Why not wait? Slide 4. From CDC reports, we can expect that for every 18 child hospitalizations prevented, at least 43 will end up in the hospital for all causes following vaccination. FDA's risk-benefit analysis only counts myocarditis hospitalization. Why ignore the VSafe data? And shouldn't FDA verify Pfizer's efficacy and immunobridging analyses first? Slide 5. Theirs shows alarming safety signals, which we have shown cannot be attributed to increased vaccinations, stimulated reporting, or COVID infections. Slide 6. We calculated the ratio of adverse events reported per million Pfizer vaccinations to reports per million flu vaccinations among teenagers to see what to expect in children. Serious events are reported 61 times more often for Pfizer, deaths 47 times, and life-threatening conditions 49 times. Slide 7. Here are the Pfizer flu reporting ratios for some adverse event categories. Look at the box on the left. What are we doing to their reproductive organs? How can you expect young children to take these risks to protect adults? Look at myocardial disorders on the right and ask yourself why Pfizer's briefing document didn't mention their child sub-study on troponin levels. You should demand to see those results. Slide 8. There are over 900 types of adverse events reported in teens from Pfizer vaccination that have never been reported for flu vaccines, including 11 cases of MIS-C with no COVID infection, and that's before correcting for underreporting. If you were hoping to prevent MIS-C, it's time to reconsider. Slide 9. The fact is, your approval today means mandates tomorrow for healthy children who don't need it and for those who weren't studied. If you have even the slightest doubt about safety, you must vote against forcing these and unknown long-term risks on young children. So in the name of millions of parents around the world, I implore you, hold the line. You won't be able to say you didn't know. Thank you.
Good afternoon. My name is Beatrice Setnick. I'm a clinical pharmacologist and consultant to various pharmaceutical and biotech companies. Slide 1 shows the total number of daily COVID cases and the current downward trajectory. Pfizer stated that most of the COVID cases observed in their study were during the July to August period, a time when the Delta variant was predominant and now makes up more than 99% of the tested strains. Despite this, the immunogenicity of the vaccine against the Delta strain was only tested in 38 children using a non-validated assay as an exploratory measure. To date, Pfizer has not disclosed any biodistribution data for this vaccine. There is evidence that biodistribution and mRNA expression in these vaccine technologies are not limited to localization at the site of injection and may potentially cause safety implications for other organs and tissues. On slide 2, the figure shows the number of COVID cases stratified by age group. COVID cases among 5 to 11-year-olds represent 5.3% of all COVID cases. 5 to 11-year-olds have one of the lowest COVID case percentages in relation to their percentage in the U.S. population, despite not having current EUA access to the vaccine. Furthermore, the 0 to 11-year-olds consistently had the lowest percent emergency department visits with diagnosed COVID. On the next slide, slide 3, COVID-19 deaths are reported by age group. Fortunately, there were few deaths reported for 0 to 17-year-olds. When we examined the age groups 5 to 11 years, 156 deaths occurred, which represent 0.03% of the total COVID deaths. The majority of COVID deaths were attributed to other comorbidities in the presence of COVID. COVID deaths in 5 to 11-year-olds were 0.008% by total numbers of COVID cases. When deaths were examined on the whole population of 0 to 17-year-olds, these comprised, and please note the correction on the slide, the correct number is 0.014% deaths relative to the total COVID-19 cases reported in this age group. The overwhelmingly high likelihood of survival rate of 99.99% in children is not a justification for emergency use. We can skip to slide 5, which shows the adverse events reported to the VAERS database following exposure to the Pfizer vaccine, with 25 deaths reported for the 6 to 17-year-old age group and 245 life-threatening events. VAERS is notoriously underreported. In Canada, 206 reports of Bell's palsy recently warranted an update to the Comirnaty product monograph. Canada has 1/10 of the U.S. population. In addition, there have been increasing reports of menstrual irregularities following COVID vaccination, to the point that the NICHD recently awarded $1.67 million in research funds to further explore this. Yet this does not even appear as an adverse event of special interest in this study. What impact does this vaccine have on our vulnerable prepubescent and developing girls? What increased risks will occur in children with the clearly short-lived and waning effects of the vaccine that will require an unknown number of booster shots in the future? The risk-benefit analysis presented today does not account for any of this. We know the risks of myocarditis and pericarditis are a real risk, particularly for young boys. Slide 6 shows the post-approval requirements that the FDA mandated to Pfizer on August 23rd. This demonstrates that many years of additional studies are required to establish the safety and efficacy of Comirnaty in both children and adults. Long-term complications of myocarditis after vaccination will not have final reports until May of 2027. On the next slide, slide 7, the guidelines for emergency use authorization clearly state that the known and potential benefits must outweigh the known and potential risks of the vaccine. Pfizer makes assumptions that vaccinations may cause substantial reductions in virus transmission. However, the CDC citation Pfizer provided clearly states that more studies are needed and that transmission does in fact occur with the vaccinated. Finally, on slide 8, Health Canada is recording a high number of reported rates of serious adverse events following the administration of the Pfizer Comirnaty vaccine, with the majority appearing after the first dose. Assuming drug safety has had devastating consequences, thalidomide being one such example that caused deformities in newborn children. In the 1990s, the FDA assumed that OxyContin had less abuse potential compared to other opioids, making a false claim that helped fuel the opioid epidemic that still ravages our children and communities to this day. Please do not assume that this vaccine is safe in our children until all data, including long-term data, has been carefully evaluated. Thank you.
The next speaker is Ms. Amy Allo.
Hello, my name is Amy Alvo. I have no conflicts of interest. I'm here on behalf of my daughter, Abigail Alvo. At age 17, she was a perfectly healthy teenager, played softball since she was 5 years old, and was cheer captain of her high school cheer team. Thinking I was protecting my daughter as she would be traveling for summer vacation, I allowed her to receive the vaccine. I couldn't be more wrong. On March 31st, 2021, Abby was given the first dose of the Pfizer vaccine. This was the only vaccine approved for her age group. After the vaccine was administered, Abby felt faint. She slept the rest of the day. The following morning, April 1st, Abby woke up not feeling well, but she insisted on going to work. A few hours into her shift, we received a phone call from HR that Abby had fainted and was shaking uncontrollably, to the point she couldn't walk. Abby was taken to the ER and rushed in. They immediately started running tests. She was given an IV with a cocktail of drugs until she was heavily sedated. She was having a neurological reaction, and no one had answers. Her final diagnosis was an adverse effect of the coronavirus COVID-19 vaccine. All of our questions and concerns were met with uncertainty. The doctors did not know. They couldn't answer any of our questions. Could Abby's injuries get better? Could they get worse as she ages? Is this the early stages of Parkinson's? No one knows. There are no long-term studies available. Abby is the study and collateral damage. All of our children will be the study. Within a few weeks of Abby's hospital discharge, we received a check from the hospital paying us back for our copay from our ER visit. Never have I received money back from a hospital. It has almost been 7 months since Abby received the vaccine. Her right arm continues to shake uncontrollably. California is now mandating the vaccine, and Abby's school is requiring her to be fully vaccinated by November. We thought we would easily get a medical exemption due to having a documented adverse reaction to the Pfizer vaccine. We requested the medical exemption. It was denied, not once, but twice. We were told there are 2 other vaccines that Abby could try. I am asking all of you today, do not allow our children to be experiments. Children are at an extremely low risk of having severe reactions from COVID. The Pfizer vaccine has no health benefit to this age group. In fact, the vaccine causes catastrophic side effects, particularly heart inflammation and neurological damage. The long-term studies are not there. It is too soon. We are causing more harm to our children. As parents and lawmakers, it is our job and duty to protect our children. I failed my daughter in allowing her to get this vaccine. Now she has neurological damage. Don't allow the same thing to happen to our other children. Please do not pass the emergency use authorization of Pfizer's vaccines for kids 5 to 11. Thank you.
Good morning from Thousand Oaks, California. My name is Belinda McCauley. I'm an attorney and a nonprofit executive, but for today's purposes, a parent. I have no conflicts of interest. I'm here to speak in strong support of approval of the COVID vaccine for ages 5 to 11. As a family who has taken COVID seriously and tried to sensibly manage risk, the expansion of the vaccine to younger kids represents a welcome and critical next step in keeping ourselves and our community safer. My husband and I have an 8-year-old daughter. We were fortunate to have the resources to keep her remote for last school year as cases surged in our region. We sent her back in person this year for 3rd grade, and she had a COVID positive classmate on the 1st and 2nd days of school. Fortunately, no other kids in her small classroom became ill, thanks in part, I'm sure, to masks. But the risk of exposure remains, including from unvaccinated volunteers that our state and school board allow in classrooms. In fact, I received a notice of another case on campus last night as I was finalizing these remarks. I'm aware that my healthy daughter's odds of becoming very ill with COVID-19 are quite low. Our concerns are primarily broader. What if she inadvertently gets someone more vulnerable sick? We have friends and family members who are high risk. My mother is in hospice nearby, so staying COVID negative so that we can visit her in the care facility is extremely important to us. And if COVID continues to widely circulate, all of us are impacted. We haven't taken our daughter to eat inside at a restaurant, to the movies, or on a plane since COVID began. She wears KN95 masks anytime she's indoors in public. I share this not to complain, but to say that we are doing what we can. But we welcome the additional protection of vaccines to help her and other kids return to more of a normal life. If the data show the vaccine is safe and helps prevent transmission and severe disease, my family is enthusiastically in favor of its prompt approval, and our daughter will get it the first day it's authorized. My friends with young kids look forward to your approval of this vaccine, and tellingly, those who have experienced COVID-19 and its effects on a daily basis are the most supportive. One friend said, quote, "My husband is an ER physician and I'm immune compromised. Needless to say, we are eagerly awaiting the vaccine approval for our 5-year-old daughter and will be first in line once it is approved," close quote. When I was growing up, my mom had a framed newspaper clipping of my grandfather from the 1950s. He was a doctor and administering polio vaccines. There was a line extending beyond the picture of kids waiting to be vaccinated. I regret that the understanding of vaccine necessity is not as broad as it was then. Those who believe in science and public health should have the opportunity to give our kids a safe and effective vaccine that helps protect them, their schools, and our larger communities. I hope this committee will provide that chance soon.
Thank you. The next speaker is Dr. Jessica Rose.
My name is Dr. Jessica Rose, and I'm a viral immunologist and computational biologist. I have no conflicts of interest. Note number 1, emergency use authorization of biological agents requires the existence of an emergency and the non-existence of alternate treatments. There is no emergency, and COVID-19 is exceedingly treatable. Note number 2, individuals with resolved COVID-19 infection are potentially pathogenically primed for subsequent Th2 immunopathology. If injected with a targeted immune stimulant in the form of a host-run spike protein manufacturing system, this could trigger subsequent inflammation, immune complex formation, and overactivation of the complement system, leading to myocarditis and other immunopathologies that are, in fact, being prolifically reported to VAERS. VAERS reports must include prior COVID-19 infection status in order to make it possible to assess the potential relationship between immune-related pathologies, including myocarditis, and the injections. Slide 1. On the left is a bar plot from a recently accepted for publication peer-reviewed paper showing the absolute numbers of VAERS reports of myocarditis according to age group. Myocarditis rates were significantly higher in youth age 13 to 23. Within 8 weeks of the COVID-19 rollout into 12 to 15-year-olds, 19 times the expected number of myocarditis cases were reported over background rates for this age group. In an act of censorship, this paper was temporarily removed and has now been killed without criticism of the work. Considering the relevance of the content of this paper to many, it seems not only strange, but irresponsible to censor this paper at this point in time. The paper is being relied upon by many for the information therein, and you and the public at large deserve an opportunity to read it. Slide 2. On the left is a bar plot showing myocarditis reports from the VAERS domestic data set according to age and dose. The data is skewed in a statistically significant way toward children. The reporting rate for boys aged 15 years is 6-fold higher for the second dose, which makes it plausible that the products are causing the adverse events and subsequent reporting. On the right is a similar bar plot according to age and gender. Of the reports, 80% of the gender classification was male, and in general, 70% of all VAERS reports are made by females, so this statistic is particularly telling. What will happen in children aged 5 through 11? Slide 3. Tens of thousands of reports have been reported to VAERS for children aged 0 through 18. In this age group, 60 children have died. 23 of them were less than 2 years old. Of the metric codes listed, it is disturbing to note that product administered to patients of inappropriate age was filed 5,510 times in this age group. This means that 2 children were inappropriately injected, presumably by a trained medical professional, and subsequently died. Slide 4. This is a table showing several examples of VAERS reports for children between the ages of 5 and 11 who died. They died within 0, 5, and an unknown number of days following the injection. The 11-year-old showed here was injected despite being too young. This is malfeasance. I implore you all to empathetically cast your vote using both your hearts and your minds. Thank you very much for this opportunity to speak.
I am Kermit Kubitz. I have reviewed the FDA analysis of the Pfizer vaccine for persons 5 to 11. I was a polio pioneer in 1955 and am making these comments in memory of my friend Tom Schiefelbein, who had polio before that vaccine and later died much too young as a result of the after effects of that disease. The FDA analysis presents an adequate analysis of the benefits and risks of lower dose 10 microgram vaccination of young children with 90.7 efficacy. As the FDA presentation notes, there have been more than 44 million COVID-19 cases, with 8.7 occurring among 5 to 11-year-olds, with 146 deaths. Hospitalized children with chronic lung disease, obesity, and neurologic disorders were at higher risk. The benefit-risk ratios and comparative scenario analysis presented in Table 14 show as my primary figure of merit prevented COVID-19 ICU admissions versus excess myocarditis ICU admissions. For the scenarios which I view as most realistic, Scenario 2 with the Delta peak of August 2021 and Scenario 4, the 90% efficacy against September 11th occurrence, approximately a 4-to-3 ratio of ICU admissions, 77 to 80 for scenarios 2 and 4 for vaccinated children versus 58 for the placebo group. This positive benefit ratio supports vaccination for 5 to 11-year-olds, and other policy considerations also do, including suppressing virus reproduction and variant development, protecting the rest of the population, including immunosuppressed or unvaccinated individuals, and reducing possible long-term effects, i.e. long-term COVID, such as my friend Tom Schiefelbein had from polio. I would have preferred a benefit-risk tabular summary in the form used by the FDA for structured benefit risk with 5 questions and answers. 1, what is the medical condition? 2, what are the available alternative treatments? 3, what are the benefits of the treatment? 4, what are the risks of the treatment? What is the summary benefit risk? Moreover, a structured benefit risk table would have been more informative and convincing to medical professions and families facing the decision to vaccinate. However, given the analysis presented, vaccination of 5 to 11-year-olds is still supported. Thank you.
Thank you. The next speaker is Ms. Christy Dobbs.
Yes, hi. I want to acknowledge to the committee that I attest I have no financial conflict of interest. And also in my speech, I want to note that I have permission to discuss a minor patient from her mother. My name is Christy Dobbs. I'm a dental hygienist, wife, and mother of 4. I am pro-science and I believe in good medicine. I received my first and only dose of the Pfizer COVID-19 vaccine on January 18, 2021. I had an immediate reaction at the hospital clinic where I was appointed. My initial reaction was a tingling sensation in my left arm where I had just received the shot. I felt as though water was dripping inside my arm. I had barely sat down in the monitoring station when I suddenly had a pre-syncopal episode. I couldn't breathe, felt hot, I had increased pulse, respiration, and heart rate, as well as a blood pressure reading that was so high it was stroke-worthy. The next 2 days following my Pfizer vaccine, my symptoms included sore arm, fatigue, swollen lymph nodes, and a headache. These are all the normal side effects I anticipated and was given as informed consent. However, on day 3 after the inoculation, the effects of the vaccine started to ravage my body. I had sharp stabbing pain in my left scapular region, as well as paresthesias and tremors in my left arm and hand. By day 4, I was having full body tremors and paresthesias, as well as an internal electrical vibration feeling, tinnitus, extreme fatigue, brain fog, muscle pain and weakness, inability to sleep, and multiple autonomic dysfunctions. I have had over 22 different symptoms that have plagued me over the last 9 months. To date, I have seen over 15 different medical providers and specialists. Back in March, I even had a telehealth visit with one of Dr. Nath's colleagues, Dr. Safavi at the NIH, and I have been specifically told not to vaccinate my children. I have sent my blood to the NIH as well as prestigious universities and private researchers looking for answers. My vaccine injury has been reported to Pfizer, VAERS, CDC, FDA, NIH, and other prominent research facilities. Messages and meetings have transpired between the vaccine injured and top officials at the CDC and FDA, including Rochelle Walensky, Peter Marks, Janet Woodcock, and Paul Richards. They have all known about these COVID-19 vaccine injuries since at least early this year. I have met countless others that have been injured by the COVID-19 vaccines, and because of the intentional suppression of these reactions, the injured have been unable to get essential medical care, research for treatment, and there is clearly no recovery plan or financial support. We are being silenced, abandoned, and cast aside as collateral damage. I have met 13-year-old Maddie DeGarry, who was severely injured and is now confined to a wheelchair with a feeding tube after receiving her Pfizer COVID-19 vaccine under clinical trial. She's been given no real medical help, abandoned by Pfizer, the test clinic, and the FDA. Her adverse event was coded as nothing more than a stomachache, and her mother fights every day for answers and help while watching her child endure this painful journey. I accepted my vaccine as a personal responsibility to my family, community, and country. He chose to participate in the vaccine trial as a brave 12-year-old child wanting to beat COVID and get back to normal. We were wrongfully coerced into taking this vaccine by prominent politicians, world health leaders, and renowned medical directors of this country. We were told that these vaccines are safe and effective, but Maddie and I are living proof that these vaccines are not safe nor effective. If we impose these vaccines on our most vulnerable, our children, it will be an absolute crime against humanity. If this happened to us, it will happen to more. We have got to protect our children. They are our future. We are real, not rare.